Hello everyone, my name is Suzan and I'm a first year PhD student at the University of Toronto, and I will be presenting a research project in collaboration of International Center for Surgical Safety at St. Michael's Hospital here in Toronto. Suzan Ayas, Dr. Gordon and Dr. Damas have nothing to disclose, and Dr. Grancher reports IP ownership from surgical safety technology outside the submitted work. A recent survey study reported that surgeons often feel distracted in the operating rooms, and a systematic review showed that distractions are frequent in the operating rooms. For example, one study reported 33 distractions per hour, and distractions may be related with adverse events. Controlled experiments found that distractions were related with increased error scores on surgical simulators, and only one observational study that looked into this relationship found that distractions were related with increased surgical errors. However, there's no robust evidence for our distractions and adverse event relationship. This is mainly because of limitations of the study designs. For example, simulator studies have only surgeons as participants, and they're mostly residents, and teamwork and other factors are excluded to have experimental control. Because of these reasons, the results may not be generalizable to real operating rooms. And observational studies are prone to missed or misinterpreted events, as they require high levels of vigilance from medically trained observers. And to address these limitations, we can use naturalistic data sets. So our objective is to investigate the OR distraction adverse event relationship using naturalistic data. And this naturalistic data is collected through the R black box platform. Is basically an operating room instrumented with cameras and microphones and other data collection devices, audiovisual recordings, laparoscopic images, and other data are collected, time synchronized, and encrypted, and they're coded within 30 days based on standardized protocols. And this coding is completed by two types of subject matter experts. First one is distraction analysts who code for distractions, and second one is clinical analysts who are staff level surgeons themselves who code for the technical data such as adverse events or surgeons' technical skills. After 30 days, the raw data together with the linking log are erased, therefore the coded data is completely anonymized. And the data that we analyzed was from 60 laparoscopic Roux-en-Y gastric bypass operations that were performed in 3 different Toronto hospitals, and this was collected through our black box platform. And the average duration was less than 1.5 hours. So as I've mentioned, we were interested in the relationship between distractions and adverse events, and we defined distractions as external sources that may lead to break in attention, and we coded 6 types of distractions. However, staff being late and loud music in the OR were rarely observed, and surgeon switches which indicated when the primary operator changed were not determinable. Therefore, we excluded those and focused on the top 3 types of distractions. So looking at our data, in 1 hour, we observed 48 distractions, which was higher than what the literature reported. These were 18 people entering or exiting the OR per hour, 27 machine alarms per hour, and 2 external communication per hour. And our adverse events were identified through the validated severe tool, and events were bleeding, mechanical injury, thermal injury, ischemic injury, and insufficient closure of anastomosis. And we were interested in the events that could lead to serious injury or even death if they were not rectified. Therefore, our analysis focused on severe adverse events. And looking at our data, we found that there were 1.53 severe events per case. Next, we were interested in the effects of procedural steps on this relationship. Therefore, we had discussions with 2 clinical analysts to assess criticality of these steps. Criticality meant here a potential danger to a patient if the step was performed without focused attention. And based on our discussions, reconstruction and inspection phases were found to be high criticality. And our data show that almost all severe adverse events occurred during high criticality steps. So our analysis focused only on high criticality steps. Next, we were interested in the surgical team factors. We had surgeons' technical skills that were rated using a modified version of the validated OSATS tool for each 20-minute blocks of the surgery, and we had nurse changeovers. Next, we had patient factors. We included BMI and previous abdominal surgery information. However, patient data was not collected from all 3 hospitals as part of our black box. Therefore, we only had access to 36 cases, which were all performed at St. Michael's Hospital. Because of this, our analysis were divided into 2 models. First model was the event distraction model, and second model was the event patient factors model. Our outcome variable was the number of severe adverse events during high criticality steps, and we divided this outcome variable into 2 classes. First, cases with no or 1 severe adverse event. Second, cases with more than 1 severe adverse event, and we ran logistic regression analyses. Our first model, event distraction model, showed that machine alarms and surgeons' technical skills were significantly related with severe adverse events, and our event patient factors model showed that BMI was only marginally significant. And in summary, this was the first naturalistic dataset study to investigate the OR distraction and intraoperative adverse event relationship, and we confirmed that OR distractions were frequent. We found that during high criticality steps, rates of machine alarms were positively correlated with severe adverse events. A potential mitigation strategy could be to use headsets to direct only the critical alarms to the entire team. And secondly, we found that surgeons' technical skill scores were negatively correlated with severe adverse events. Strategy could be to train for technical skills to mitigate the effects. And we found that BMI levels were marginally significant. This was only to show that we need to collect patient data as part of our black box in our future studies. And our main limitation was the sample size. So in our future work, we want to increase the sample size. And this was a retrospective analysis on prospectively collected and anonymized data set. Therefore, our access to additional patient data was limited. And we only had distractions that were coded as the protocol had. Therefore, extra distraction types such as conversations and equipment-related issues were not captured. And we were not able to explore interaction effects because of the sample size. And this study can inform mitigation efforts, which our research team is currently working on. Thank you for listening.